Evening, everyone, and it's a pleasure to be here on the inaugural webinar of the Academia of Minimal Access Surgical Oncology. I hope I'm audible, Rudra? Yeah, okay. So I have a very esteemed panel here, and before we start, let me just make this disclosure. I've been in touch with them, and except Dr. Jagdish Powdar and Dr. Somashekhar, who have an isolated floor in their own facility, and Professor Vijay Kumar also, who have been dealing with the COVID patients once in a while. Everybody else is by and large working in a practically COVID negative environment. So, we have had a very good lectures regarding the laparoscopy, regarding the triage. So I thought it will be good if we can discuss about the practical aspects, and for that we invited the champions for learning to know from them as to what are the practical issues on the ground and how are they trying to circumvent it and speeding their path. So the first issue is, of course, we have the preoperative testing protocol mentioned by Professor Vijay Kumar. Can I ask Dr. Sandeep Naik, Dr. Sandeep, are you also doing the same amount of preoperative testing, or is there any difference, and how are you spacing the testing in your patients vis-a-vis the surgery?
Present, we are only doing this testing, and generally we do it a day or two prior to the surgery, and if it is negative, we go ahead and continue with the surgery. So we are not doing CT scans. We are, in fact, the reason why we are not doing is, in fact, I suggested to my radiologist. They said it will be difficult for them to run all the cases through CT scans because of the load that they face. So that's what they frankly told me, and then we said, okay, fine, we are not going ahead. So as far as this is the only test we are doing as of now. Okay, please.
So may I know from Dr. Saklani, are you also doing the same, and are you admitting the patients? How long early are you admitting the patients before the surgical procedure? Because the protocol says that you must observe the patient for at least about 8 to 10 days before the surgical procedure is undertaken, whether you do it on OPD basis through video consultation, or whether you keep the patient in-house and monitor them for symptoms of ILI. So what's your protocol? Do you admit them beforehand, say 5 days beforehand, and do all the testing?
No, we follow the hospital policy, so we don't have to think much about it. What we do is, for asymptomatic patients, 48 hours before that, the RT-PCR is done. They don't do for PAC or any other thing, because we'll have to do contact tracing if they come positive. The report comes back the night, and we admit them the next day for surgery. And once they have surgery, advanced recovery, we try to send them home on 23. So that's the best way that we are following so far, because that is the hospital policy. So any other thing?
Okay, so your hospital policy does not dictate thorough testing and waiting before the patients are operated on, is it?
No.
Okay, and since you are in the hotspot, Mumbai, is demographics making a difference? Are you isolating the patients, or they get isolated at the screening table itself?
No, I think for wherever there is acute care setting, there are 3 parts of the hospital. So the first part is where people who are unscreened, people who are there, which need to be screened. The second area where if they turn positive, that's the second area there. And the third area would be the clean area. So actually only 1/3 of beds are available to us. So the number of beds are so limited, but all the areas are clearly isolated, so there is no mix.
So can I request, Sir Professor Vijay Kumar, sir, you elaborately mentioned about that testing policy, and it is very understandable that different hospital settings will have different limitations, and of course the different COVID load, and also whether COVID negative or positive. So what should be the optimal strategy, the minimum optimal strategy for testing the patients before surgery for any cancer? So
before I directly answer, we'll have to know certain tests are not available at all in our country.
Yeah.
Artificially made, I would say, by the ICMR, not allowing to be done as a routine. Whereas in a state like Delhi, by the magistrate, they are telling every admitted patient has to go through RT-PCR.
Yeah.
Right? So
Yeah.
different states have got different policies, and center coming into the picture here, ICMR is trying to say that RT-PCR needs to be done only for ABCD. They are given the indications. Wherein, if you look at it, elective cases are not at all there. If you in fact see the indication, there is only one column called others, which you have to tick, and then only you have to upload them. And every RT-PCR done in this country by either private lab or by any government lab has to be intimated to ICMR. The moment it is positive, it has to be, of course, it is going to come to everybody's knowledge, but we are allowed to specially intimate to the surveillance officer of that particular district. These are certain issues which make many people take a back seat to openly do this and inform them. Having said that, in our country, with all these mixed issues, every institution is doing their own policy. And as I understand, most of them are doing RT-PCR, whether it is a formal or informal. They are doing it, and then only they are taking it. But the problem I feel in this, scientifically speaking, when it is negative, I am really worried, because 1/3 of the times the positive can be negative. So that means every third patient who we are taking as negative may not be negative. We should not become casual with all the patients just because you have done RT-PCR. That is why I am insisting that treat or consider every patient who is now coming to us as though they are positive, and protect ourselves by preventive measures, rather than doing an RT-PCR or IgM and say it is negative and be casual about it.
Okay, and do you think one should go ahead only on the basis of RT-PCR? Of course, serology is present at some places, not present at some other places. Or do you recommend RT-PCR and some waiting time in the hospital?
I don't recommend RT-PCR at all, if you ask me personally.
Okay. Or you are
everybody is positive and take precautions, I'm telling again and again. Because RT-PCR, if it is positive, it is useful not to do surgery, agree. Because those patients, the morbidity and mortality is considerably high, and so we may. Whereas if you are looking at this triage to take them in, that's not the right way of doing. That's my personal view on the subject after reviewing it. But most of the centers are doing RT-PCR at our eyes.
Yeah, I would just mention that in our hospital, the protocol is that we do the RT-PCR on the operative, on the OPD setting on, say, day 1. We send them home, do the video consultation for 4 days, call them back on day 5, do the serology and the HRCT test, then keep them admitted for 3 days, and then we operate them on the day 8. Somehow, if you look at the entire protocol, perhaps it gives, I've been discussing with Som yesterday, it gives about 96% accuracy of being sure that the patient was COVID negative. But then I'm sure.
Little louder.
Okay.
So, Rajesh, but only thing in Bombay, if they go back, the risk of community transmission is very high. So that's why we cannot send them back again.
No, you cannot send them back. Plus, I'm sure the kind of workload that you have, I understand the various limitations that you will have. And therefore, one policy may not actually hold well for all the hospitals in the country. Situations are very diverse, government regulations are very diverse. So let's go on to the next important issue. Dr. Som did mention his and showed his consent chart. Because I've also been involved in some bit of policy making in my hospital. Consents are a big issue, and despite the fact that the patients of cancer will, if the doctor advises, invariably they will give the consent. What are the major consent issues or the changed consent issues? I would request Dr. Jagannath Dixit and Dr. Gowda to comment as to what's the difference in the consent that you are taking now. Dr. Dixit, please.
Yeah, sir, we have made one of the important consent form, and this pre-anesthetic checkup, rather than taking it just day before the surgery, the consent, we take it almost 2 or 3 days prior to the surgery, and it is clearly explains that that risk involved. Suppose that false negative rate and false positive rate of the testing, and it also includes the some of the healthcare workers and how the protection we need to take and all that. I think these measures we do.
Dr. Gowda, your comment, please.
Yeah, initially we have a COVID floor in our hospital, and another hospital we have a separate building where there is a COVID patients are there. So what we did is we left it to the physicians as a first line interaction with the patient. And because as what you told, no, 8 days, 7 days, which is not possible with our center, we explain them that most of the Telangana government doesn't allow COVID RT-PCR. Whereas for robotic and lab, we have made certain arrangements, which is actually what Vijay Kumar saw is informal. It's not as per government restrictions. We also do it. For some patients, we have sent to Karnataka and did it. So we tell the patients open surgery, we are not doing RT-PCR, and we have one floor of few COVID patients, and we tell them about the transmission and a special consent, and we tell the OT staff and the higher risk of surgery in case, like we had 2 patients later on turned out to be positive. So we don't know which patient is positive, which patient is negative. We inform them the possibility of COVID positivity and high risk consent. These 2 things only we tell them. And our health workers also, we inform all the risk factors.
Great, I think you have covered almost everything. And in my own opinion, I think 3 things were very, very important, apart from the fact that they might have higher rate of complications if they turn out positive later on, despite the intense screening or pre-operative testing protocol. I think in the private sector, it becomes important to mention to them that the cost is going to be high, because not only the testing, the PPEs, the cost is by and large borne by the patient. So the cost is getting higher. And of course, there is always a risk for contracting COVID from the hospital. And I think this particular risk is going to become more important as we go ahead with the COVID era. Because obviously all patients stay in the hospital for at least about 8 to 9 days or 10 days. I'm not talking about colonic and the rectal resections, but most patients will stay in the hospital for about 8 days. And there is a possibility, and this actually happened in one of the hospitals in the north, and there were issues about it. So before I go on to the other controversial things, particularly in the last 2-3 days, everybody must have seen lots of coverages from various articles and controversies and discussions about the HCQ prophylaxis. May I request Dr. Subramanieshwar Rao and Dr. Devinder Parikh, have you taken HCQ prophylaxis? All your HCQ prophylaxis, and what's your point of view?
Not as yet. I've been contemplating, discussing. Each day I have a different opinion about myself, to be very honest. I've not done it as yet. I don't know what I will be doing. Honestly, I don't know whether I should be taking it or not, whether I should be advising to the rest of the staff. I'm not convinced either way, to be very honest. I'm confused about hydroxychloroquine prophylaxis. Me and my wife keep discussing each day whether to take or not. So we are going day after day. We are not started as yet.
Okay, very understandable. In fact, that's the situation with most healthcare workers. Dr. Parikh, your comment?
At our place in Ahmedabad, we have a lot of corona positive patients, and as a institute protocol, our hospital have started 2 months back. Every single healthcare professional is taking 400 milligram. So what we are taking is 800 milligram loading dose and then 400 milligram weekly dose, and we are continuing with the same dose at this point of time. All the senior members of our team are underwent cardiac status evaluation before taking HCQ prophylaxis. But at our center, at HCG Cancer Center Ahmedabad, we are taking HCQ prophylaxis.
Okay, so let's just have a very quick one-word answer from almost all the esteemed panelists. Dr. Nayak, yes or no?
No.
Okay, so prophylaxis, yes or no?
I have taken in our institution. It was the institution of policy. We took it. It's very difficult. See, if we had a randomized control trial, this question would never have happened. This controversy is because there is no conclusive evidence even to the tune of level 2B. We don't have it. The only thing I would look at the other way around, what is the harm in taking HCQ? The cardiac issues, GI and other are not well confounded. Now that we have 4 studies from India, so I take it up to individual people to balance the complications.
Dr. Dikshit?
Sir, actually, to tell you frankly, I started taking the tablet and I continued for 2 or 3 weeks. Then the ICM suddenly said that there is no point and better to discontinue. So I stopped almost, and it's a surprise that after 2 or 3 days, so, and there is a clear indication that probably I'm thinking to restart now. And but I had one consultation with one of the rheumatologists and immunologists, a good friend of mine. But what he was advocating is the lesser dosage, probably because we are also stressed because of the surgery and other things. Probably none of us, we have got an annual checkup of ECG and echo. Probably our friend was advocating, we can take almost half the dose. Rather than going for 800 mg, take it 400 mg and continuously, then on a weekly basis dosage, half the dose. So probably that also might be going to give the equal result as the full dose.
Dr. Rudra?
Yeah, as per the max policy, I am taking since March actually. And after this latest ICMR report beyond 8 weeks, I'm going to take maybe more than 4 weeks.
Dr. Saklani?
No.
Okay. Sir, Professor Vijay Kumar? Are you there? Okay.
Mute.
Sir, are you there?
Sorry, I'm sorry, I muted. My answer is no.
Okay. So in the House is divided, almost about half of the people have taken, half of the people have not taken. In fact, there was this revised guideline from ICMR yesterday, which has actually advocated the grounds may not be very well established. It is obviously not the basis of any well-designed studies. The House is divided, and so is the kind of opinion all over the world. The ICMR has advised, and at our own institute, we kind of procured a lot of HCQ, gave it to almost all the healthcare workers. I myself took the first dose, loading dose of 400 milligram BD on the day one. Next week, I got scared, so I started with 200 milligram for 3 weeks. Then I got some literature, so I got confident again, so I'm on 400 now. Okay, that's the status. So I think it's divided and we don't have an answer. Regarding the PPE, of course, there are lots of variations which are available. I think let's not go into the details, but I'll show you certain pictures. And you can see one on the extreme left, which is white, which I started with, did 3 procedures and kind of gave it up and then came into these universal precautions. May I have a quick yes or you just one word answer, perfect or optimal PPE? Should it be a combination of a perfect headgear and an optimal gown, or a perfect headgear and a perfect gown, meaning thereby that you have to cover the entire body? What's the opinion of the House? Dr. Som?
None of the PP are good for head and neck cover. Perfect cover for the head and an optimal gown is fine rather than the other way around.
Great, exactly. So, and Dr. Gowda?
I use a half face respirator with goggles on my specs, and PPE for robotic and laparoscopy, and a routine gown for open surgery.
Okay, great. So I think most of the people would now agree that almost about 1 to 1.5 months down the line into the experience, we have realized that the full PPE, the kind of the hazmat suit, was very uncomfortable to wear, and on the top of that we were wearing gowns. So I have myself now reduced down to the universal precautions which we used to take for the HIV and hepatitis patients. But along with that, a very good headgear. One of the problems with the headgear that I have shown here, which comes from 3M, which perhaps most of the cancer surgeons are using, was that it does protect you, but it is a kind of a respirator and it does not protect the other person whom you are talking to, because you inhale and it tends to come out. When you inhale, it gets the filtered air. So this new, you can see this kind of attachment is now available in the market, although not in good quantity. So you can actually attach it over your respirator and prevent the...
Dr. Rajesh, we are not seeing the picture.
You have to share your screen.
You have to share the screen.
Share screen is not... Oh, sorry. I think the screen must have been shared.
No, it is not that.
Oh, I'm so sorry.
We are only seeing ourselves.
Okay. So this is the one that I was talking about. This kind of attachment. Are you getting to see that?
Yeah, see.
Sure.
Now we are seeing, yeah.
Okay, so this kind of attachment is now possible, available from the 3M, and that actually prevents problem to the person you are talking while you're operating. So this filter acts both ways. So coming to the theater environment, it has already been discussed and presented by Dr. Somashekhar. The important components, I'm not going to list them again, but temperature has to be less than 21, humidity less than 65, air exchanges have been discussed, minimum positive pressure has been discussed. I would want to know from the champions as to how much have you been able to handle in your theater? Have you been able to leave apart the negative pressure, because negative pressure is only exceptionally available in Indian theaters. I've also been trying to ask many people. That's not negative pressure, that's not possible. But everything else, has that been possible, or can you compromise on that thing? Dr. Rao, please.
We have been audible.
No.
Am I audible?
Yeah, now better.
So, internet is very unstable, sir. Am I audible?
Right, yeah.
Yeah, so good. Carry on.
Yeah, please.
Yeah.
You are audible.
Yes. We can hear.
Yeah. See, I would say that we are following most of it, at least, if not everything. There may be a bit of compromise sometimes, but most of the operation room part of it, we follow everything. But the PPE for the surgeons, only when we suspect and then investigate, only then we are actually using PPE.
Oh, so you're not using PPE otherwise?
The headgear is used, but the rest of it is regular gowns.
Oh, okay. So that essentially means that you are not treating everybody as a COVID suspect. You are depending on the testing.
Correct.
Okay, great. Dr. Dikshit, any comments?
Correct.
The major problem is that whenever we do a surgery which amounts to almost about more than 3 to 4 hours, probably the face shield, especially the face shield, and whenever we sit in the robotic console, it cannot recognize unless you remove the face shield and put your head and inside, and then the instruments will start working. So that is the greatest problem. So we will be having a 3M mask with a respirator with a cartridge which can be detachable, and also that whatever the spectacles already we are having, probably that will be good. But the face shield is the one which comes in the way, and also whenever we keep a 21 and 8 degrees centigrade temperature inside, lot of suffocation, and then lot of sweating, and even the area of contact of the nose, especially where the 3M mask fits, probably we need to have a important because this sweating is really discomfort. We need to wear a regular mask over that to put a 3M mask, because this it's very uncomfortable. I think sometimes we really have to remove 2-3 minutes and then take a deep breath and restart the surgery. So it's really I want to know the experience of other surgeons, because we are not used to that. So we are really it's not a very comfortable for us.
Yeah. In fact, that's perhaps been the experience with most people. Dr. Rudra, any comments?
Yeah. At our place, we always use the full face respirator from 3M with the P100 cartridges. Right. And we use, like you, the commonest universal precaution HIV for the shoe cover and the thing. But one thing we are doing is very simple, is after you wear that helmet, one of the OT seats that we put in the on the patient is taken with there is a tape with a adhesive tape attached. So you take out the paper and you can just put it on your the full face respirator in the face and make it completely covering your neck on the back, and then you put the gown. So what happens is, from the head to toe, everything gets covered, and the neck is completely covered around the over that helmet. So we found it very effective to cover everything of your body.
Okay, so that's great. That's a good indigenous modification. Dr. Parikh and Dr. Nath, any comments?
I have one comment that once Dr. Somashekhar sir has also mentioned that in OT it has to be a protocol that all the participants will have same level of protection.
Yeah.
So if one of the colleague is using valve respirator and another one is using simple respirator, then person using simple respirator is having more risk compared to someone using valve respirator. So at our hospital, couple of surgeons are using valve respirator and couple of them are using N95. So that is very dangerous situation. And one of the hypotheses people made that in OT all the surgeons and staffs are COVID negative, but in Ahmedabad we have seen surprises. In our hospital we have seen two surprises in which one patient in which we have sent pre-operative RT-PCR, that is COVID testing. We have performed surgery as that test came negative, and after one day, authority from laboratory came to us and said that there was mistake. Another patient report came to us, and actually your patient positive. Then there was a lot of problem. So I guess we have to treat all patients as corona positive because eventually we will see more.
Yeah, you're right. Dr. Nayak, a quick comment, please.
Yes.
Dr. Nayak, am I audible?
Nayak is missing actually. I think he's lost his.
Dr.
Rajesh.
Dr. Rajesh, what I feel, we have tried 4-5 different, including air purifier. We are only 60% efficient most of the time, and I feel I am taking very high risk in our hospital, especially when we are doing robotic and laparoscopy. Sometimes air leakage is there around the straight ports, and suddenly some new sister comes and lets off the air. And when we are using the full face respirator, it's a repeated detection problem and loss of movement. And sometimes I wear goggles over my specs and humidification and not able to see the structure scope. So I feel personally I am taking only 60% efficient and 100% or more than 100% risk doing these cases. Don't know what modifications will come in the future. That's my personal opinion.
Yeah.
Now, Rajesh, can I add something?
Sir, please.
We've been discussing about the in operation room prevention, protection, and everything. The same patients, we are discussing about universal prophylaxis. The same patient goes into an ICU where 24-hour care. Here it's all controlled, 2-3 hours, 1 hour, 5 hours. There, again, the same PPEs to so many staff members are also extremely important. I have a 54-bed ICU. See, the biggest challenge is how to really supply PPEs and maintain a channel this way, and how expensive it's going to become if you are doing a universal prophylaxis.
You are absolutely right. In fact, I also tried to review the literature, and the literature does not suggest that the respirator is any more effective in filtering the virus than N95. The only advantage is that probably it reduces the work of breathing, and so that you can sustain the respirator and you can sustain without a discomfort for a longer time. And one of the important factor is that it is very categorically mentioned with the product, even with N95, that every single time you touch the mask and put it down onto the neck to breathe and put it up again, it is considered one doffing. And one mask should not last for more than 5 doffings. ideally, and you should ideally not be doffing the mask during every surgical procedure, even once, ideally. So there are things which need to be understood and discussed, and probably with time we will have some evidence as we go. But that's been the typical setting that we operate upon, and here also you can see the anesthetists have a different set of headgears and the head shields and the N95 and on the top of that the surgical mask, whereas the surgeons have these respirators. Okay. Now, just again, maybe we have understood, we have heard SOM is a very a prominent proponent of minimal access even during COVID, which is so good, which is so kind of encouraging for all of us. And at the same time, we have some reserved opinions regarding the risk. So basically, it boils down to understanding whether the person, do you think, are the laparoscopic outcomes superior enough to justify taking the unknown risk in the era of COVID-19? Or do you think the risk is not significant enough to justify sacrificing the advantages of minimal access cancer surgery? So can I have a quick opinion, just one liner from everyone? Are the laparoscopic procedures good enough to not be afraid? Or do you think that the risk of COVID is not significant enough to get bothered? Dr. Saklani, please.
Hi, Rajesh. I think we are just overplaying it. Even for hepatitis patients and HIV, we are using MIS rather than open. So, like Somu showed in his last slide, it isn't there. So, I think
risk is not enough.
I think the benefit is there. Less blood loss. There is no blood in the blood bank. Less pain and less wards breaking. And also, the staff don't have to look after them. So, you have to look after staff as well. So the patient contact is less. So I think minimal access is justified.
And Dr. Rao has already mentioned his opinion. They're not taking the complete precaution, which means the risk is not probably enough. That's their mindset and the thought process. Dr. Gowda?
Yeah, we are selected our cases and doing. For example, esophagus, low angle resections. These cases we are doing renal masses, but thyroid, colon, and stomach we have stopped. So we have segregated our cases.
That's my next question, actually.
And doing robotic only rather than laparoscopy.
Yeah. Dr. Pari, your comment: is the risk less or is the benefit more?
I guess benefit is more. So we have continued. We have not changed our indications either for surgery or for approach.
Right. Great. Dr. Rutra?
I think
we are continuing with the all types of surgery. And recently, I operated a big sarcoma involving the clavicle, scapula, and the right humerus. And it took almost 6.5 hours along with the replacement. So, and there was a lot of aerosoling from the bone cutting, from the bone cutters.
So probably you feel that the risk is not all that high.
Yeah, no, because we are taking all the precautions, and we are doing, because there is no other way. You just have to intervene in the window period. If the window is lost, the patient goes to palliative setting.
Actually, but sarcoma is a different issue, because as it is, you would have done it open. I was talking to minimal access part. But then, so when I was trying to read about it, and the latest article in the journal, they made a very good statement regarding whether to choose open or laparoscopic. And for every surgeon, in the absence of convincing data, this was just about 4 or 5 days, in the absence of convincing data, when both open and laparoscopic approaches are clinically as good and as appropriate, the safest approach may be the one that is familiar to the surgeon and which requires less operative time. So perhaps you produce the same results because you are used to something. And I'm sure all of us who are deep into laparoscopy for cancer, we realize that for a person who's into laparoscopy for something, say rectum all the time, it's open operation does not come all that easy to begin with again.
Absolutely.
I think Rajesh, Sandeep is back. So Sandeep is back.
Okay, hi Sandeep. So you're back. Okay. So
yes, I'm back. I had electrical issues, so I had to switch over, and I can't come on this thing. Video is not possible.
Okay, thank God. The electricity back, and we have the current back from you in the webinar, so we catch up with the excitement. And as Dr. Devinder Parikh just mentioned, I try to think about the magnitude of the procedure, and representative of magnitude of the laparoscopic procedure that we routinely perform. So would want to know from the panelists as to like start from staging laparoscopic resection for colonic cancer, then rectal cancer, then D2 gastrectomy, then thoracoscopic epidectomy, then laparoscopic pancreatic or liver resections, and finally the cytoreductive surgery. Are there any opinions that in the COVID era, I am not going to go beyond this level 3 or level 4 with laparoscope and wait for level 5, 6, and 7 or something like that? Can I have a quick opinion from all of you, please? Starting from Dr. Saklani.
I think I would recommend everything apart from laparoscopic pancreas, and HIPEC we cannot do because the intensivist won't allow it. Other than that, I think everything should be quite okay.
Dr. Rao?
Yes, we have done CRS, HIPEC, three of them, and we have done everything the same way. So we have not changed anything. For the patient gets the same thing that used to happen before January. Yes.
That's a very encouraging comment. That's great. So Rudra?
Yeah, same thing I was telling. But my point is, if two senior surgeons are required to go in a case, don't hesitate, because if you do if the operative time is less, then everybody is going to benefit. So that way, whenever required, we just in and finish the case early, because sometimes it benefits.
Okay. Dr. Parikh has already mentioned his point of view. Dr. Nayak, a good comment from you on this.
Yeah. So regarding the HIPEC, we have not done HIPEC so far. In fact, we delayed a few of the cases which were there. We put them back on chemotherapy. All the other surgeries we are doing. As far as thoracoscopy is concerned, in fact, it is very interesting. When I was seeing another Spanish surgeon discussing regarding this, he said, a gasless thoracoscopy is much safer than going ahead with open surgery, because there is absolutely no aerosolization there because there is no gas coming out.
So in fact, I was trying to search the literature on this, and I could find 2 articles of thoracoscopy in COVID era, and they were regarding thoracoscopy and such. But one of the articles was actually doing a thoracoscopy with a non-intubated patient. So
non-intubated
patient without any positive pressure and under local anesthesia, they have done probably a biopsy or something, and one
fluoroscopies they do. Yeah. Yes. But for our procedures, it's not possible.
So we don't have.
I had one more comment regarding the PPE, because I think at that exact time my electricity problem started. See, we have designed a head and neck cover, which is just like a monkey cap, which we tuck into our dress, and that covers the entire neck, head, ear, everything, leaving out only the face. So we use the 3M respirators, but this monkey cap I think is quite good, which we have done. We are calling it monkey cap. It is just like monkey cap. It works wonderfully for covering your neck.
Anybody who has done an MIE, minimal invasive thoracoscopic esophageectomy in the last week, I believe Dr. Rao must have done it. But
I've been doing it regularly. We have done a lot of robotic esophagectomy. We have not changed any of them. In fact, a well-controlled, minimal access is better than an uncontrolled open surgery. You're bathing with fluid, you're using cautery non-stop. Because I showed you in my presentation, the use of cautery and the setting and the amount required in open surgery is far high, and everything is open. Everybody is taking. So, it's a well-controlled environment in MIS, and all you need to do is wet out through.
I think what sums up is what Rajesh told. What you are used to, it's better you continue.
Correct.
And continue what you are used to.
Sir, any comments, Professor Vijay Kumar, sir?
No, I'm only learning. Because I'll tell you, I'm serious about it. Because I'm really confused. In a teaching institution, too many people are putting their eyes, hands, everything.
Yes. So that's going to.
And the surgeons don't listen to anybody else.
Yes.
That's the problem. And the anesthetists will not listen to the surgeons.
Yes.
Environment, like for example, Dr. Subramanian Shara's place, where he says and the whole thing may listen, but that doesn't.
No, sir. No, sir, I'm an
I'm
anesthetist at
just
home,
telling
at home also.
too many people, too many opinions. And the most important thing I learned in the last 2 months is people work from their emotional point of view, not the rational one. Because not having anything, so they were anxious, apprehensive, and they thought what they are telling is right. So things were not at all under control, I would say.
Yeah, so I'm going to address these questions very
People are falling in line, and as you rightly said, they are going back to the January days. That's all is happening. So to even convince my anesthetist, I am thinking, as I said, I was listening here to go and tell. Because as of today, in my setting, open surgeries are only going on, and they were not willing. Anesthetists were not willing. They were worried, so many things, because the reports were caught in the beginning. And then they are now slowly going to staging and then moving on. But it is to take along a lot of team of people with different views and different ideas is probably a bigger challenge than going and operating.
Okay, I think procedure modification has already been covered by Dr. Som. And coming to an interplay with NSET and NSETRT, one comment from Dr. Saklani regarding the CA rectum, how you have changed and interplayed with NSET and NSETRT, and are you delaying surgeries based on that? And one comment from Dr. Rao regarding the esophagus and the same setting NSET.
I think the problem was giving radiotherapy, get patients coming for this was a bit difficult. So because they didn't have transport, so the long course chemoradiation was changed to short course radiotherapy and 4 cycles of chemotherapy. Now, if there are poor responders, we are operating now because there are fewer patients. Otherwise, we will give consolidation chemotherapy. We normally wait for 8 to 12 weeks, but that we continue the same thing.
And have there been any patients who had already received, say, NSET or NSETRT in January or February and were due for surgery, and for some reasons you eventually gave them definitive chemoradiation and opted out of surgery? Were there some patients?
No. I think all those who came, because we are still running a 6 to 7 list per week, so we were never closed down. So we were able to sort it out.
We also have not changed the protocol. Surgery, when it is required, we are continuing.
Okay, now regarding esophagus, same protocols?
Same.
Nothing else?
Everything. Okay. The patient before January, patient now is the same.
Okay. Dr. Goda?
Yeah, same. We are doing esophagus, rectum by the same protocol. We are not postponing or doing anything as per the previous protocol. And we are even doing lung cases also. It's not a problem.
Okay, all right. Dr. Pari?
Only the waiting time we have made little alteration. We following PRT instead of doing at probably 7th or 8th week, we are 7th week. Some of the rectal cases and even esophagus 6th week. Probably, and now we need to analyze those waiting for a longer time has got a better pathological response compared to the. I think this is the ideal time to look back about 5 cases versus another 5 cases which have happened. I think this is the right time to dig our results and also see that.
The new research protocol.
I have two comments that for MIE to doing esophagus by open approach is, I personally feel that it's not acceptable if you know how to do MIE. So I personally don't believe in opening up the esophagus. First thing. Second thing, earlier we were doing esophagectomy in teams. So one of the surgeons were doing thoracic part, second surgeon was doing abdominal part. But now in the era of COVID, now we have segregated the teams. So even if one person is exposed, not entire team will be non-functional. So now at present in our team, we have 4 senior surgeons in quarantine. So we have made a team that surgeon who will start the case will finish the case. And in that way, even if something went wrong, then only one person will be out of the worst. So that is what we have done.
In fact, that's the part of most of the guidelines, that changing of teams is perhaps not desirable. And what happened, and I'll just share with you briefly our own experience. We had a suspected positive patient in the ward which was there with us for about 5-6 days, and eventually we found that it was not operable, and everybody was exposed, including all the gastrophysicians, so 4 of my associates, all the residents, and it was suspected positive. So the day when we thought that it was positive, somehow we realized that almost all of us were exposed. And had she been actually positive, we would have had to shut down the entire department. So this was about 1.5 months back. So we decided, and now what we have done is, like for example, in our unit, there are 4 consultants. So it is 1 consultant and 3 residents who make a team, and they work for 1 week. And then next week, the next team takes over. And the moment there is somebody who gets exposed, the first team goes into retirement for 7 days and the next team takes over like that. So it prevents the entire department from getting exposed and gives a more practical situation on the ground.
Rajesh, there is one most important thing, which we approved in the committee in doing. The moment a patient gets in, making a contact form, like each medical healthcare workers, not just doctors, sisters, everybody, when they see there is a sheet, you have to write what is your contact with that patient or what are the level of protection you are wearing. Because we know that managing the patient with PPE, if that patient eventually becomes positive, you are not a primary contact as per ICMR. So every patient should have a contact form, contact of each healthcare provider, and when they contacted that patient, say a sister managing or a doctor came for a cross referral or a surgeon operating anesthetist, what level of protection they are wearing. So suppose one patient turns out to be positive, you don't have to close the whole block, close one surgical department, whole anesthesia. You know the contact and their primary contact for easy for quarantine.
Yeah, absolutely agree with you. In fact, this was because the government guidelines have been changing, and in Rajasthan there are designated COVID negative and COVID positive hospitals. And 1.5 months back, when it so happened, there were guidelines for not doing an RT-PCR on everyone who got exposed. Just after this patient happened, there was these guidelines, and the moment we reported that this patient could be positive, because one of the reports had actually come positive, and we now know that an inappropriate, that was the time when our institution was not doing the RT-PCR. So it was done at some other center, and it was reported positive. And it is a well-known fact and an established fact that if during the testing the quality is not maintained in testing in terms of transporting the sample and managing the calibration, etc., false positives can be because of a poor quality control at the testing facility. So if this patient then eventually turned out negative on 2 subsequent testings. But then now there is a guideline that if there is an exposure, it's very easy. You do either a serology or an RT-PCR and quarantine based on that. And of course, I understand, ICMR has also defined the level of contact, which gives you the level of risk of having the COVID from that. The same question as Professor Vijay Kumar sir was saying. So what's the role of anesthetist? Has the role of anesthetist changed? Who has become the leader of the theater now? Have the checklists changed? And who affects the decisions? Have there been any patients who have been changed because the anesthetist was not willing or kind of had a different opinion on the patient? Dr. Nayak, is he there? Okay, I think Dr. Nayak, he has some problems with connection.
Is there?
I'm there. He has some problem with his anesthetist, I think.
Anesthetist probably more than virus.
Yeah. No, our anesthesia department is quite good that way. In fact, the head of the anesthesia puts all the protocols, is in the COVID committee also. And in fact, initially in the period when there was lockdown 1, of course, most of the things were shut, but we did a few cases which were emergency, but otherwise most of it was shut. But in the lockdown 2 onwards, everything actually bounced back to normal. And in fact, they took the lead and telling us that we are willing to start your elective one. We are okay with that. That's how.
Incidentally, Nayak's wife is an anesthetist.
Yeah. She doesn't work with me, sir. No, she does not work with me. It's difficult to work with wives.
Okay, so great. So, in fact, what has happened in the high incidence areas, particularly in the US and places like Boston, what they've done is they've formed committees wherein there are representatives from every discipline, be it surgeon, anesthetist, gastroenterologist, interventional radiologist, radiotherapist, oncologist, everyone. And every single case goes through that team which tries to identify which is the best course forward in view of the prevalence of COVID in their area and the region and the availability of the alternative modality of treatment which can suit the patient as well as the surgery. And despite the fact, and they're trying to avoid surgery wherever possible. Okay, so we have already, I think, discussed this. As Sir was mentioning, how has the surgical learning for juniors changed? I think these juniors who have some very important years in their career for training and learning, they have a major concern that they might actually lose out on their training for the next 6 months or 1 year just because COVID is there, the volume is less, the protocols have changed. They might not get their hands upon operating the patients because you want to operate upon them in the smallest possible time without any glitches during this procedure. Can I have a quick comment from you, sir? First, Professor Vijay Kumar, sir.
This is a very major issue if you ask me in a teaching institution like us,
Yes.
particularly any teaching institute,
Yeah.
because we are now worried whether we give it to the juniors, if they get affected, I'll feel guilty that COVID, he has become COVID positive because I allowed him to do. On the other hand, if I don't give, you'll not learn the subject, learn hands-on training. So this is the balance probably you'll have to take. And most of the time, we'll hold. In fact, that my institute was closed, OT was closed for elective for some time in the first lockdown. Then it was opened. The first surgery was done by me, Whipples. I said I will go and do surgery first so that it will induce enthusiasm and the fear will go out, and then we started doing. I thought that's what I did, and my team is now doing. Everybody is doing.
Great leadership. Dr. Saklani.
I think because of the rota, 1 week on and off, they're very limited exposure and with limited theatre time and all. So I think it's mainly the fellows and consultants who operate. Unfortunately, they are going to lose out. There's very little we can do for them.
Correct. I agree with Dr. Rao.
Yeah, similar. I think it would affect things. It has affected Olympics. It has affected lots of things. So it would affect their training a little bit. There's no doubt about it.
And
that's what is happening.
Is there any way we can compensate for that? Maybe through video lectures, video demonstrations, discussions in-house?
All that is happening. Web-based programs have got escalated to a level wherein there is a different type of learning that is happening. So we are glad we have explored lots of other avenues actually. So there's a lot of good that has happened because of this.
Yeah, yes. we have actually realized that there could be many good forms of training and teaching.
Correct.
Som, your comment, please.
In my hospital, not much has got affected because when I post a surgery, I sort of clearly know my fellows and students at what level of training are they and what they can independently do. So I allot in such a way that the team allotted would just finish it off without having to call me or my other colleague to come. But I think 2 to 3 months is too small because I would say 80% they are doing the same training what it was pre-COVID. But it will get compensated because training is not just 3 to 4 months. It's for 3 years with us in my department. So marginally down, but I don't think it didn't matter much in our hospital.
Dr. Naik?
We have, minimal access fellows, surgical oncology fellows. Yes, it does affect. I think some of the cases they would have done, but now only seniors are washing up. So only 3 of us, the seniors in the team, are washing. They only get to assist, and it is a concern. But I think if let's hope the situations improve and we are able to give them more hands-on little later. But yes, 3 months they will lose definitely.
Yeah. Dr. Dixit.
Things won't improve. We will only readjust.
Correct.
Yes,
my
maybe
something of Darwin and adaptability.
Yeah, virus will not adapt. We have to adapt.
Yeah, let's see how we adapt.
We are looking at a fast recovery of the patient without having any complication in the intra-op and post-op, and probably, we are looking at that same surgeon who has done the repeated work. Probably, let us continue and finish it off. Probably, rest of the surgery, the later half of the surgery, like closure and other things, would be given to our fellows and residents. Yeah. So that's how we are continuing and making the work to go.
In fact, the guidelines, obviously, they are kind of entering their training because it is the one surgeon who's operating. We want minimum traffic in the ORs. We don't want any observers to stand there and see. And so obviously it's affecting, and perhaps it is the junior most training. Say, if you have an MCH program, it is not the third year, it is the first year or the second year the subject more. I also realize, but I think we need to find out some innovative ways to compensate for their training. And probably
and Rajesh, on that count, I think minimal access scores over open because you can record and show it to them later on.
Correct. Yes. Yeah. COVID-19 has posed some new issues which kind of challenge our pre-existing notion of ethics for a surgeon. If you get a obstructed CA, say left colon, with inadequate PPE, should you operate? Should you not operate? Dr. Saklani?
No, I think it's our first duty is to the patient. So you have to operate. Hopefully, you'll have adequate PP. But then you can cut down the magnitude of surgery. So you may just come out with stoma or something if you don't have PP. If you have adequate PP, then do the perfect job.
Dixit?
I think the same. Most of the time, all these patients are having a small stricturous lesion in the sigmoid colon, and the surgery is the form of the treatment. I think all these patients, irrespective either open or MIS, probably the surgery has to be done. But since we have passed that phase, we are already using the PPE. I think it's the right move to start using the PPE and start doing the RT-PCR for every patient.
I agree with you. In fact, this issue was much more there in the beginning, say 1.5 months back, when there was a shortage for PPEs, and the entire world was struggling for PPEs, and there was this big ethical question whether to kind of treat and kind of involve and indulge yourself with the patient without that adequate PPE. The second important ethical question is, if it is a non-urgent operation, patient has an unknown COVID status, your government is not allowing you to do the RT-PCR, you have enough and adequate PPEs, the patient is consenting for surgery, but despite that, you might have on one ground or the other. Say, for example, if you say that your staff is not well trained, or if you do not have isolating facilities, that your ICU may not have the adequate equipment, etc., etc. So these two things have actually kind of changed the ethics. So what has happened is, there has been a shift of focus from trying to benefit our individual patients to focusing on the benefit of the community. So at times, the benefit of the community is taking preference over benefit of the patient, because if you have only, say, 3 surgeons in that hospital who can deal with that and the entire maybe big district, you might not want to expose yourself because you have to serve the community at large. And second is, there is a greater shift and there is a greater level of paternalism that we have been used to in previous decades. So despite everything, earlier on, if the patient was consenting, you did not have the right to refuse a patient based on some other grounds. But now the decision making is much more on the surgeon. I think that brings to the end of the kind of relevant questions on the ground that we had. Thank you all very much for participating. And now I think we can take questions from Dr. Rudra, which he has gathered through the chat. Thank you all very much for being here.